I'm Kendra. I'm with EDS Wellness. I've been part of the EDS community, working within the community for a number of years. I'm happy to introduce Dr. Alan Pocinki. Dr. Alan Pocinki is a clinical associate professor at George Washington University Medical Center and a private practice physician in Washington, D.C. Through his private practice, Dr. Pocinki has developed a strong interest in the relationship between joint hypermobility syndrome, Ehlers-Danlos syndrome, and autonomic dysfunction. Because of his patient-caring manner, his patients have consistently voted him one of the top primary care doctors in Washington. We are thrilled to have Dr. Pocinki with us once again to share his experience and insight on the relationship between EDS and dysautonomia.
Thanks, Andrew. Thank you. Actually what Lauren asked me to do was to talk about Ehlers-Danlos syndrome without talking about autonomic dysfunction, which is kind of hard to do, so, as you'll see. But I think she felt that enough people in the POTS and dysautonomia community probably come across terms like hypermobility, joint hypermobility syndrome, Ehlers-Danlos, and maybe needed to know more about the symptoms and problems of patients with Ehlers-Danlos syndrome beyond simply their autonomic issues. And in fact, I've just come from the National Ehlers-Danlos meetings where yesterday I gave a talk on the evaluation and management of autonomic dysfunction in Ehlers-Danlos patients. So I'm kind of coming full circle here to talk to autonomic patients about Ehlers-Danlos syndrome. And we spent a lot of time at the conference deciding exactly what the diagnostic criteria and exactly who has it and who doesn't. So I'm not going to go near that one today. But suffice it to say that Ehlers-Danlos syndrome is characterized by increased tissue laxity and or fragility in general. Most obviously and most commonly that affects the joints, and the joints are hypermobile, lax, or have an increased range of motion. Laxity is most often measured by the Beighton score, and I'll show you that on the next slide. But it's important to realize that virtually every organ system can be affected. So although our working group at the Ehlers-Danlos Society was tasked with preparing a consensus statement on evaluation and management of autonomic dysfunction in Ehlers-Danlos patients, in fact, they made our jobs easier by asking us to limit that to the cardiovascular system, which is just a very small part of the autonomic dysfunction we see in Ehlers-Danlos patients. So please don't even look at this for more than a second, just to give you a list of the various types of Ehlers-Danlos, but they're all associated with increased tissue laxity and tissue fragility, and the most common type is the hypermobile type. So this is a little questionnaire that the British hypermobility folks put together just as something they could literally leave in the waiting room for their patients to fill out. And I won't ask for a show of hands here as to how many people amuse their friends with joint party tricks when they were kids. So here's the Beighton score is a 9-point score. Basically, you get 1 point on each side for being able to touch your thumbs to your forearms, 1 point on each side for being able to extend your pinky to 90 degrees or further, 1 point on each side for hyperextension of your elbows and your knees, and then you get 1 point for being able to put your palms flat on the floor without bending your legs, as this person could do. So, and generally, a score of 4 to 5 out of 9 is considered to be significant. So as I mentioned, Ehlers-Danlos really is a multi-system disorder. You can basically go from head to toe and think about every organ system in your body and how it might malfunction if its parts and pieces were overly stretchy. So as you might imagine, I can't go through every organ system that I've listed here in the time I have available, but just to give you an idea of the breadth, I'll go over I'll mention the more common ones. So, and the other sort of, for me, this helps to put pieces together, and I think for patients it helps to sort of understand where their symptoms come from, that the majority of symptoms that hypermobile patients have either a mechanical basis, that is, they come from tissues that are just too stretchy or don't hold together properly, or they have an autonomic basis. So if we look at the joints, clearly most joint problems are mechanical. There's premature osteoarthritis, both because loose joints wear down faster and because we think the cartilage is softer, the collagen, the cartilage isn't as rigid as it should be. Of course, periarticular soft tissue strain means basically as you move a loose joint and it slips and slides around, the muscles around the joint get sore and get strained, trying to hold that joint together. Those strained muscles often tighten up. And that gives rise to the paradox of loose-jointed people saying, gee, I'm not flexible, I'm stiff. And that's a very common problem. It's important for physical therapists to recognize when there's a loose joint underneath all that tight, soft tissue. Premature disc disease is another problem. Again, the discs are made of collagen. If the collagen is not rigid and not stiff enough, then over time those discs are going to collapse and break earlier in hypermobile patients than in others. Circulatory problems are both autonomic and mechanical ones. The ones that are more mechanical are venous pooling, where those of you who heard Dr. Previous talk, the veins simply are too stretchy, so that when you stand, blood that should be moving back toward the heart instead is pooling and sitting in these big stretchy veins. So that gives rise to an increase in cold hands and feet, a tendency to orthostasis, and literally when veins get too bulgy, you get things like hemorrhoids and varicose veins. So in the head and neck, mechanical problems, a big issue is TMJ problems. People can give hour-long lectures just on TMJ problems. There's problems with the joint itself being unstable. There's problems with the neck and the soft tissues of the neck being strained for other reasons, putting pressure on the jaw. Chiari malformation, I'll mention again a little bit later. Chiari malformation is basically when the brain stem slides into the foramen magnum, which is the opening in the skull that the spinal cord leaves the brain and comes through. And over time, if the tissues that are supporting that stretch, the brainstem can actually sink into and be pinched against the skull. I mentioned premature disc disease. A high arched palate with crowded teeth, meaning normal arches like this. Ehlers-Danlos patients tend to have an arch like this, so then they don't have enough room for other teeth. So it's very common for patients to have teeth pulled when they're younger. Now they have palate expanders to help fit in their teeth. Digestive problems also can be mechanical or autonomic. The mechanical ones often are just dysphagia, meaning it's hard to swallow. The tissues here that should constrict are too loose and floppy and don't generate enough force. And in fact, yesterday at the Ehlers-Danlos meeting, the British group presented some data using what's called manometry to measure the pressure generated in the esophagus when it contracts as it's supposed to be moving food down along the way, and found that on average, Ehlers-Danlos patients' force of contraction was 15% of normal. So, and you can imagine then the risks of reflux also, that the lower esophageal sphincter isn't as tight as it should be, and your stomach does this when it should be doing this, then you've got stuff sitting in your stomach longer. So there are a lot of mechanical problems, and chronic constipation is a major problem in the hypermobile population, partly for autonomic reasons, but partly because the colon simply does this when it should be doing this. So on the more sort of autonomic side, certainly most of you here are familiar with the circulatory issues of lightheadedness, fluctuating blood pressure, palpitations. A lot of gastrointestinal symptoms have an autonomic basis too. I see a lot of patients who have long-term nausea, who've been to the gastroenterologist and been through all kinds of testing with no explanation found for their nausea, and it turns out that their nausea has primarily an autonomic basis. Cramping can be autonomic, cramping can be mast cell, cramping can be all kinds of things. Urinary problems are very common because of mechanical bladder dysfunction, because of autonomic issues, because of pelvic floor issues. Respiratory problems are tricky. A lot of people just, more often than not, are told by friends and family members that they're breathing funny, and they're not aware of it. They may sigh a lot. They may find a rapid, shallow breathing pattern. One of the most common complaints is, it's hard to get a deep breath. Some people will even find that when they go and have pulmonary function testing done, because to evaluate their, we call dyspnea, their trouble breathing, it looks like they have mild asthma, because they have an obstructive pattern. They go to breathe out and their airways collapse, not because they're inflamed from asthma, but because they're too collapsible. They're not as rigid as they should be. So very common for Ehlers-Danlos patients to say, oh yeah, I was told I have asthma, but I have this inhaler thing and it never helps. Right? So vestibular problems are a common autonomic problem that I don't see mentioned very often, and that's just regulating your balance. And if you think about how your heart rate and blood pressure and other things are not kept on an even keel, but instead do this too much, then you'll understand why a lot of people have trouble with balance. And the other big issue with balance that I'll come to again later is what we call position sensor proprioception, and that how your brain knows where your joints are in space basically is generated primarily by, as the joint moves, it pulls on the tissues around the joint, and that sends a message to your brain that the joint's moving. Well, if as the joint moves around, the tissues around the joint are so loose and floppy that they're not really getting pulled on at all, then your brain doesn't really know where you are. I see that particularly in patients who have a lot of hip and pelvic instability, that they feel unsteady when they're walking. And neurologists who aren't used to doing joint exams have trouble figuring out where this instability and balance problems are coming from. Anxiety is another issue that I've given hour-long lectures on, but suffice it to say that most anxiety in the hypermobile population is probably autonomic. It's probably the sympathetic excess. It's what I call over-response to stress. All you need is a sympathetic surge from any kind of stress, and you'll have palpitations and tight chest and shakiness, and you'll quickly rattle off all the diagnostic criteria for a panic attack. Body temperature regulation is something a lot of patients complain about that we don't really understand well, but people are cold when other people aren't cold. They'll be cold one minute, hot the next. I don't have a good sense of what that is, but it's a common autonomic problem in the hypermobility syndromes. And again, sleep problems is something I've also given hour-long talks on, but there's a particular pattern of sleep disorder that we see in the dysautonomias and in the Ehlers-Danlos patients, and that is characterized by a lack of deep sleep and by frequent disruptions to the continuity of sleep, or what we call arousals. So, talked about a little bit about muscle and joint pain, and the symptoms that patients have obviously are pain around the joints from muscle strain, a tendency to tendinitis, joint subluxation, joint dislocations. A lot of what patients describe as joint pain, physicians misunderstand, and it's really not joint pain. It's pain coming from the soft tissues around the joints. And that, to you, feels like joint pain. How do you know whether the pain is coming from inside your hip or it's coming from the tissues right around your hip? That's for your doctor to try and figure out. But the hip is a good example where patients complaining of hip pain will have an x-ray. The x-ray is normal, so the physician will deduce that it must be bursitis and give them a cortisone injection, which of course doesn't help. So we can go head to toe again, looking at joint laxity syndromes. Chronic neck strain, chronic headache is way up there, basically for two reasons. The ligaments that are supposed to support the head are too loose and floppy, and so that puts extra workload on the muscles to hold up your head, and two, the shoulders are often chronically subluxed, and then these muscles are always tight. I've taken to describing this as a tug of war. The shoulders are constantly pulling the head down and forward, and then all these muscles in through here are constantly trying to pull the head up and back, and neither side wants to let go, and patients cannot get relief from their neck pain. Similarly, TMJ pain, it has to be considered that neck problems are part and parcel of TMJ problems. People who just see a dentist for their TMJ problems, who don't recognize how much the posture of the neck, position of the neck affects their TMJ, are going to have problems. They may get their teeth straightened out, and then once their neck is fixed, they're going to have their teeth straightened out again. I've seen it more than once. Costochondritis is a common syndrome, which is inflammation of the cartilage here in the rib cage, where the ribs simply move around too much. And there's no fancy joints here. The little pockets that the ribs sit in get irritated from movement. And this can cause both the sort of chronic chest tightness as well as occasional sharp chest pains that often send people to the emergency room. Low back pain is another common problem, and it's, again, very often it's another one of these tug-of-wars where because the hips and the pelvis are loose, the quads, which are the strongest guys in the neighborhood, will tighten up to try and hold things in place, but that tightness tends to pull the weight forward, and that triggers your lower back to try and pull back. And in this tug-of-war between the quads and your lower back, your quads are going to win, and your back's going to hurt. So just another reason why it's hard to maintain upright posture for long periods, besides the difficulty of maintaining blood flow to your brain. Sciatica is another common problem where the small muscle called the piriformis muscle is very important for stability of the pelvis, and if the pelvis is loose, the piriformis may get strained and tighten up and pinch the sciatic nerve, and very often this is misdiagnosed as a disc problem, and patients have disc injections and other things when the problem is really mechanical. Cardiovascular issues, again, most of you are familiar with these. Can probably even just skip right over this. The one I'll point out at the bottom, dilation of the aortic root is one of the more serious complications we worry about in people whose tissues are really stretchy, then the walls of their arteries are too stretchy, and right at the base of the aorta, which sees the maximum pressure from each heartbeat, the aorta can stretch and weaken over time. So GI problems, very surprisingly over the past few years, we've recognized that in the Ehlers-Danlos population, the most common symptom that patients present with is pain, the second most common symptom is fatigue, and the third most common turns out to be digestive problems. So we talked about upper GI problems with esophageal spasm, the esophagus not contracting well, delayed gastric emptying, your bowels not being regulated properly, but being regulated the way your heart rate and blood pressure is, one extreme or the other, up and down. Prolapse of pelvic organs is a problem where the supporting structures, the uterus, for example, is essentially held up by two ligaments. Over time and gravity, those ligaments can stretch, and you can end up with a prolapsed uterus sitting on top of the bladder. One other point that I want to mention here at the bottom, one cause that I see fairly often, a cause of abdominal pain that is localized abdominal pain. People say, well, it always hurts right in this spot. And that's something I refer to as abdominal wall tears or abdominal wall defects. And these are basically weak spots in the musculature of the abdominal wall. The abdominal wall is made up of a bunch of different muscles. There are places where the muscles themselves don't tear, but the fibers holding two muscles together will tear and weaken and stretch. So in that localized area, instead of being there being a layer of skin, a layer of muscle, and then intestines underneath, there's essentially a gap in the muscle layer, and an air bubble in the intestines can put pressure on the abdominal wall and cause pain. And this is something that, I'm sorry, can we hold questions till the end? And this will cause pain, and this does not show up on a CAT scan or a sonogram or a colonoscopy or anything like that. And these are easily recognized and diagnosed in the office, except that physicians think they're rare. So we talked about respiratory symptoms. Just going to mention that apnea occurs with increased frequency in the hypermobile population because of the laxity of tissues in the back of the throat collapsing more easily during sleep. So more serious complications in the GU tract are urinary urgency and frequency and even incontinence. Urinary incontinence makes us concerned about something called tethered cord syndrome that I'll mention more in a minute, but we always worry that may be a neurological problem. We just talked about prolapse. I put a question mark next to endometriosis because it appears that endometriosis is more common in the hypermobile population, but I don't know that it's ever been published and anybody knows that for a fact. I'm not sure. Sexual dysfunctions are a common thing. A lot of patients are not comfortable bringing up to their physicians, but has to do with pain from stretch. Interstitial cystitis, I just heard yesterday that some urologists are now calling this hypersensitivity cystitis. And you might have heard Dr. Afrin mention interstitial cystitis in his talk on mast cell disease, and I think some of us have thought for a long time that interstitial cystitis is an inflammatory condition that's probably related to mast cell hyperactivity. So hopefully there'll be some more treatments coming as some better understanding of interstitial cystitis comes along. And then one fairly common cause of pelvic pain that's not related to pelvic organs per se is what's called venous congestion. You can see varicose veins in your legs if you've been standing too long, but you can't really see them in your pelvis. There's a lot of pooling that happens in the pelvis. If your pelvic veins get bigger and bigger and bigger, they can actually become uncomfortable and painful. It's a fairly easy diagnosis to make, but not something that most physicians think of. So there's a lot of skin problems, and people have loose, stretchy skin. The biggest one probably is that wounds don't heal well. If you get a cut, normal skin will sort of gradually heal back together. If your skin is loose and stretchy, it's going to be stretching apart at the same time it's trying to heal back together. And you'll get these wide, thin scars that obviously don't heal well. This is somebody who's got obviously very stretchy skin. And this person here, I think this slide is to show stretch marks as well as a poorly healed scar. So, neurological symptoms are very common. I think certainly a lot of POTS patients complain about brain fog. The Ehlers-Danlos community in general has been surprised when they've asked patients to rank their symptoms, that neuropsychiatric symptoms come up fairly high on the list. And that can be anything from cognitive symptoms, trouble with concentration, trouble with memory, things like that, shakiness, numbness of various types. Tinnitus is a common problem that can have various causes. I mentioned briefly about impaired position sense. Lots of people are clumsy and klutzy, and combine that with easy bruising and poor wound healing, not a good combination. And headache is particularly common. I think at one Ehlers-Danlos meeting, a few of us sat down and in no time at all thought of 15 or 16 different types of headaches that Ehlers-Danlos patients are predisposed to. So more serious neurological complications we worry about. Craniocervical instability basically is the head being unstable on the spine. And that can be a serious problem with too much tension or pressure on the spinal cord. Chiari malformation, I mentioned. Syrinx basically is a collection of cerebrospinal fluid around the spinal cord. Normally the cord is bathed in fluid, a small amount of fluid, but that's a thin-walled sac that the spinal cord is in, and if there's any increase in pressure within the system, that sac can stretch and you'll get a leak or a pool of cerebrospinal fluid, and that's called a syrinx. And then occult tethered cord. Most of us, when we're born, the spinal cord is free floating. Originates from the brain, comes through the opening of the skull, and it's floating in the spinal canal. In some cases, however, there are small fibers that remain at the base of the cord, attaching it to structures there and putting pressure on the cord. That can be very difficult to diagnose because in at least half of cases you don't see these little fibers on MRI scans. It can be very confusing because, as you might imagine, you can pull here and get symptoms up here if you're pulling the spinal cord against that opening in the skull. So one of the hallmark features we look for is bladder problems, and there are specific findings on bladder testing, so-called urodynamic testing, that are useful in ruling in or ruling out tethered cord syndrome. But many times we can't tell for sure, and it's left to the clinical judgment of the neurosurgeon to go in and look for these tethers and cut them if they're found. And I don't think I need to talk about autonomic nervous system dysfunction. So here's a very short list of the various, some of the more serious causes of headache. The two that I'll point out are both increases and decreases in intracranial pressure are common in the hypermobile patients, and these are very hard to diagnose clinically. Patients will describe an increased intracranial pressure headache as it feels like my head is going to explode. Unfortunately, because of the stretchiness of the whole system, often if you do a spinal tap and look at the opening pressure, you would think, well, okay, there's too much pressure inside the brain. You'll see increased pressure within the, but you don't, because because the system has stretched. You don't see that increased opening pressure. And then recently there's been a lot of interest in problems of venous drainage within the brain. There are also what are called venous sinuses. Blood gets pumped into the brain. It has to come back out through these veins. There can be pooling in the venous sinuses. Imagine if you have varicose veins, how heavy and uncomfortable your legs feel at the end of the day. Imagine what would happen in your brain if the veins inside your brain are swelling and putting pressure on things. And there are even some concerns in some patients in whom blood clots have been identified in these venous sinuses because the blood is pooling and sitting there so long. Psychiatric symptoms, the couple I'll mention are just that depression is obviously very common in any chronic pain syndrome and needs to be recognized and treated, because without appropriately treating depression, you're not going to get your pain under control, you're not going to get a decent night's sleep, your fatigue's not going to improve. And then anxiety, as I mentioned, is often an autonomic symptom, and I also see ADD also often as an autonomic symptom. The example I usually give is if you haven't had a restful night's sleep in many years and you're trying to do something cognitively demanding, you're going to have trouble maintaining focus, you're going to be irritable, you're going to be distractible, you're going to procrastinate, you're going to go right down that list of ADD symptoms, and a well-meaning physician is going to prescribe you stimulants, which is going to make everything worse. So I included this just for completeness. I'm not going to talk about endocrine dysfunction. It's too controversial and not clear-cut at all. The only illustration I will mention here, just for interest, because it may affect some of you, I see a fair number of young women, and one I saw yesterday at the Ehlers-Danlos meeting, who said she does 2 hours of physical therapy a day, and she's a string bean. She can't build muscle no matter what she does. And so out of curiosity, I drew testosterone levels in some of these women, and they're essentially zero. And I don't know why that is, and I've asked people in the endocrine and GYN community to help me understand that and haven't gotten anywhere. But clearly it seems to be a manifestation of endocrine dysfunction. Hematologic complications, easy bruising is common just because the skin isn't rigid enough to protect the blood vessels underneath, and so minor trauma causes large bruises. There are reports both of increased bleeding and an increased risk of clotting that we're going to probably end up leaving to the geneticists to sort out. And then iron deficiency, I just mentioned that often iron deficiency is caused by malabsorption rather than blood loss, and patients go through extensive testing to try and figure out why they're iron deficient when it's not a blood loss problem. Immune dysfunction, I hope some of you or most of you had a chance to hear Larry Afrin speak this morning. All kinds of immune problems we're now finding are associated with Ehlers-Danlos syndrome. And mast cell disorders, again, I think you guys hopefully heard this morning. And then the only other point I was going to make about pain, just for my patients, find it helpful to think about different types of pain, to think about pain that's mechanical, pain that's inflammatory, and pain that's neuropathic, to understand why different treatments may help different kinds of pain and why their best approach to pain management is probably going to be a combination of modalities. And fatigue is another hour-long lecture probably, but I make the point that most common causes of fatigue in Ehlers-Danlos syndrome are chronic pain and poor or non-restorative sleep. And poor sleep is something that I've been interested in because I'd see patients who said, I go to sleep fine, I sleep through the night okay, and I wake up feeling like I haven't slept. And they would have a sleep study, and the sleep study would be read as normal. And I, always cynical, would look at the sleep study and say, there's got to be something wrong with your sleep if you're tired when you wake up and you've slept okay. And so the common findings here, as I mentioned earlier, are a lack of deep sleep and an increased number of spontaneous arousal. So very commonly, people will have something like 125 or 150 disruptions to the continuity of their sleep in 6 or 7 hours of sleep. And I've shown in previous talks data suggests that this is an autonomic problem. This is related to sympathetic hyperarousal and often responds to treatment with things like beta blockers. This is a slide I borrowed, which just makes some of the same points that if you haven't slept well, you're going to have cognitive problems and a bunch of other problems. And then lastly, somebody asked me just to include a comment about variability in drug metabolism. And we seem to find that a lot of Ehlers-Danlos patients have unusual sensitivities, unusual reactions, need big doses of certain medications, only tolerate very small doses of certain other medications. The only report like this that's actually published is a general resistance to local anesthetics. A lot of patients find that the usual local anesthetics like Novocaine and lidocaine either don't work at all or wear off very quickly, and very often the physician who's administered these things doesn't want to believe you that they've worn off. So I have these two reference articles that I keep in my office and occasionally need to fax them to somebody's dentist. So then, summarize, Ehlers-Danlos can affect essentially every organ system, every part of your body, causing lots of different symptoms and occasionally serious complications. The majority of symptoms are caused either by mechanical or autonomic problems, and obviously identifying the underlying cause for a specific symptom is critical to choosing the optimal treatment. So thank you. Thank to my colleagues who encouraged me when most of my other colleagues thought I was nuts when I first started getting interested in this. And I always thank my patients because most of what I know I've learned from what they've told me and from how they've reacted to the treatments that I've given them. And of course, thank Dysautonomia International for putting together a conference and all their work in spreading knowledge and awareness and advocacy. Thanks. So, if we have time for some questions. Yes?
Okay, so 2 questions. I'll do the first one real quick. Epilobic appendicitis, is that tissue issue? Like, would that come up as epilobic appendicitis?
Sorry, I'm not sure I know what that is.
It's just fat cell inside your stomach. It's like super common but never caught. But for me, it always hurts me. It feels like diverticulitis. And I always think it is diverticulitis.
Yeah, I mean, there are situations where things get rotated and twisted and pinched, so there may be something near your appendix that's getting twisted and pinched. Yeah, so.
And glaucoma and EDS patients, how do you treat that? Is it the same treatment?
Do I look like an eye doctor?
I know it's common, and my boyfriend recently got diagnosed with EDS, and he has glaucoma at the age of 25.
So, and I'll readily admit that I learned this last month. So, so I will share what little I know, and that is that when most physicians think about glaucoma, they think of impaired blood flow into the eye because there's too much pressure in the eye. But those of you who have very low blood pressure and/or orthostatic intolerance can have what's called normal pressure glaucoma, which means there isn't enough blood flow into the eye because the blood pressure isn't high enough to get it there. And that then is the standard treatments for glaucoma, which are drops to lower the pressure in the eye, don't work for that. So that's what I know about glaucoma and Ehlers-Danlos. Okay? Yes? Right. No, I wish I knew, and we all in this very small field share your frustration that people go, without being diagnosed, or they go to their primary care physician with a list of problems and are, either told they're nuts or say this is more than I can deal with, come back when you're feeling better. Yeah, I mean, it's difficult for a primary care physician to manage this. I've always thought that rheumatologists would be the obvious ones because this is primarily a joint syndrome, and they do manage them, and they do manage some multi-symptom illnesses, but most rheumatologists don't recognize hypermobility when they see it. So that's, sorry, I don't have a good answer. Right, I mean, there are physicians listed on the DI website and I think there's some on the Ehlers-Danlos website. The EDSawareness.org lists local Ehlers-Danlos support groups, and a lot of local support groups keep lists of physicians and other knowledgeable professionals in their areas. Not any new ones. I've got my hands full, sorry. I don't know where to start. Yes.
Okay, so I'm looking at these long lists of symptoms and thinking, okay, probably most people would say, oh, I have
Right. Well, as I said, we're currently arguing about exactly what the diagnostic criteria should be. But generally, if you have significant joint laxity and you have symptoms in several other organ systems, so you have GI involvement, you have neuropsychiatric involvement, you have autonomic nervous system involvement, you have, right, any of the other poor wound healing, easy bruising, it's a syndrome. It's a constellation of symptoms. So, yeah, and among the difficulties of doing this is highlighted. I saw a young woman this week who's 20 years old who was diagnosed with Ehlers-Danlos at Hopkins in 2012 because she had POTS and she had pain and she couldn't sleep and she was exhausted and she was irritable and she couldn't concentrate, and she no longer has any of those things. She's still on a beta blocker and some clonidine to regulate her autonomic nervous system, but she's off of all the rest of her medications. She's working as a camp counselor, and if she came to me today, I wouldn't be able to diagnose her with Ehlers-Danlos. So it's difficult. I get a side of the room. Yes?
When you said the respiratory symptoms, did you include excessive yawning without being tired whatsoever?
Yeah, yawning kind of goes with the heavy sighing. There are some people who get the yawns. We also see the yawns as a side effect from some of the serotonin drugs. People who take, small doses of lexapro after some of those drugs can sometimes cause the yawns. But yeah. I could have made a page-long list of respiratory symptoms too. Typically the heavy sighing is probably the most common things that other people notice, and then the sense of hard to take a deep breath is probably the most common thing people complain about. Somebody on this side, yes.
Aside from sleep, what would your number one self-care recommendation for relatively newly diagnosed EDS patients be?
Adequate pain control. What would be my number one recommendation for a recently diagnosed Ehlers-Danlos patient? Most people, by the time they're diagnosed, have been in pain for a long time, and it often comes to be what I call background pain, that you've gotten used to it and you say, oh, it's not that bad, I can live with it, I can put up with it, I don't want to be taking pain medicine. But recognizing that being in pain all the time is contributing to fatigue, is putting you at risk for depression, is affecting the quality of your sleep, and you're not being some kind of wimp by taking medication when you're in pain. Yes?
Just a question. Have you talked about for the intrusions at night, you can give beta blockers. Do you find they're improved if you give fluoride-ethyl or those that can help with the sleep, or just the beta blockers?
No, as I said, the problem with the sleep seems to be sympathetic hyperarousal. So drugs that block or offset the sympathetics will help. Midodrine you're not going to take in the evening anyway. And fludrocortisone, I'm not a big fan of. I find most people just need more salt. They don't really need to be tricking their kidneys into holding on to more salt. They just need more salt. Yes?
Is EDS an inherited condition?
Yes, it is. It's autosomal dominant. So that means there's a 50-50 chance. So that means when I see young people come in with both parents, one or the other of them has it. Often they both deny it. That's not uncommon for both of them to be loose jointed. No, usually it's direct, but again, this is issues of what the geneticists call variable expression and variable penetrance. Two people can have the same genes and not be equally affected by it. In general, men are much less affected than women, at least to some extent. I think that's because of testosterone, and it's easier to build and maintain muscle tone for men and take some of the looseness out of the joints. Yes?
How do you see it relating to celiac disease? Because I have a younger daughter. I think probably both daughters do have this, but as well as their celiac disease, as well as POTS. But I see my younger daughter, and she couldn't really walk very well until I took her off of gluten. So after that, she actually can walk better, but she does have a lot of these other symptoms as well. So I'm just wondering, it did seem to improve the picture considerably, but and I also was curious about vitamin D deficiency and also intestinal lesions after surgery. Right. So that's why
I skipped over the fatigue slide because I could spend an hour talking about evaluating fatigue in patients. Yes, certainly important to look for vitamin deficiencies because of limited diets and because of tendencies to malabsorption. Vitamin D, B12, and magnesium are probably the most common micronutrients I see people be deficient in. I was surprised, as I said, I just saw yesterday a presentation from the British hypermobility, the GI group, and the British hypermobility study group, that about 35% of their Crohn's patients were hypermobile. So there's clearly some overlap with all forms of autoimmune disease. So it wouldn't surprise me if celiac is more common, just as we get into the mast cells and the hypersensitivities to soy and egg and other things. Isn't my time up yet?
As far as anesthesia goes, two things. One, would you consider epidural issues as well as anesthesia? Because I had 6 epidurals throughout the 2 pregnancies that did not work. And then also, as far as anesthetic, during surgery, I have trouble. They have to give me like a really big person's amount of anesthesia to go to sleep, and then it takes me forever to get up. You were saying kind of opposite?
Yeah, there are extremes on both sides. There are small people who take need big doses of medications. There are big people who respond to small doses of medications. You can be a fast metabolizer of certain medications, be a slow metabolizer of other medications. Yes, unfortunately, I've heard epidural horror stories too, of patients being unable to convince their obstetricians that, yes, I can feel your hand on my thigh. I think it's supposed to be numb there, and still not getting more anesthetic.
Yes, I would like to come back to this combo of POTS, EDS-free, and mast cells.
Okay.
My daughter was diagnosed POTS, and then EDS, and then mast cells. And I am wondering, and what else after?
Believe me, there are times that I've been reluctant to tell somebody, that, oh man, do I have to tell this person they have mast cell disease too?
This combo for me is fascinating, and it was not my daughter, but I would like to understand a little bit more. I'm not a physician, so I need simple answers. But
I guess you didn't get any simple answers from Dr. Afrin.
I talked with Dr. Afrin this morning. In his opinion, the basis, the foundation is the mast cells.
Right,
From the mast cells, everything can happen.
right.
You go to POTS, you go to EDS, you go to fibromyalgia, you go to diabetes, you go to a myriad of stuff. Doesn't seem your interpretation, doesn't seem your approach. So I would like to understand where we are.
Well, I think you can you get a sense of what's been happening in the Ehlers-Danlos community. Even I'm sure Larry probably mentioned there are several competing diagnostic schemes for who has mast cell disease. We can't decide who does that. Certainly, there are some very highly regarded people in both fields who think that it is possible that tryptase and elastase and some enzymes made by mast cells may be inhibiting the cross-linking of collagen in hypermobile type Ehlers-Danlos, and there might actually not be anything wrong with the collagen per se, and that's why we can't find the genetic defect in the collagen in hypermobile type 3. I think that's something that several people who have stored serum specimens and things like that, people are going to start looking at that. Certainly mast cell dysfunction is going to aggravate autonomic dysfunction. I mean, at a very simple level, one of the basic effects of histamine is to make blood vessels leaky. Fluid leaks out of the vessels into the tissues, and your intravascular volume drops, and there goes your heart rate goes up, and so on. So it's not, right. It's hard for me to say that mast cells cause everything, because clearly I have patients who we can treat their mast cell symptoms and all their mast cell symptoms get better. That doesn't make their unstable joints any more stable.
No, but if you address, in the case of my daughter, the issue of the mast cells, we have seen, not from a very long time, but still, some real improvement on
Oh, definitely. Right.
And that's interesting to run the
Oh, yeah. Yeah. No, and I see people whose sleep improves, whose pain improves. I see all kinds of symptoms improve. I've seen, patients on high doses of narcotics who have multiple operations to stabilize their necks, and they're taking this huge pile of pills, and I give them a little cromolyn to take, and they say, I can't believe how much better I feel. So yeah, it's there, and the more we look for it, the more we find it, and treating it often. It's very important to ask about it. Uh-huh. To ask about mast cell symptoms in anybody who's autonomic. Right, right. Just as we think it's important for physicians to look for hypermobility in their in their POTS patients. Okay, I got time for a couple more questions, I guess. Yes.
You said the first thing you do is treat pain. Can you say how you go about that?
Well, somebody asked if she's newly diagnosed, what would be the first thing besides sleep? So getting a restful night's sleep and getting pain under control are probably the two biggest contributors that I see to autonomic dysfunction in the Ehlers-Danlos population are chronic pain and non-restored sleep. How do you treat pain in Ehlers-Danlos? We don't really have another hour. That's right. And that's what I talked about. You need to identify how much of your pain is inflammatory, how much is mechanical, how much is neuropathic. You need to work on, physical therapy, a home exercise program. You need to work on improving sleep quality because that's when you heal, is overnight when you're sleeping well. It's almost as I said, it's a lecture unto itself. Sorry, I can't be more specific. Okay, maybe one more. Yes.
I'm sorry, I didn't know, I came a little late, I didn't know if you had commented on pelvic vein ablation.
Yeah, I did mention pelvic venous congestion, as being a cause of chronic pelvic pain that's often hard to find or hard to think. I mean, it's easy to find if you think of it, but most physicians won't think of that. And there are patients who have, it can be a factor in orthostatic intolerance. It's more often people do ablation for chronic pelvic pain from venous congestion. But there are people I know who've had, in the old days, we used to ligate. We used to tie off those veins so they couldn't fill up with blood. Now there are fancier methods, but there's a lot of what we call reservoir or capacitance veins in your pelvis. So one way to increase your effective circulating blood volume is to take those out or laser them or do something to them so they don't store so much blood.
So do you have patients that pursue that in POTS, or?
I've had the few patients I've seen have done it for pain rather than for POTS, yeah. Okay, thanks.